Good afternoon, everybody. I hope you enjoyed your lunch. My name is Matthew Hulse. I'm a senior health specialist with the World Bank, where I coordinate a lot of our digital and technology work. I'll be your moderator for today's session. Shortly, I will talk through the structure of how this session goes, as well as introduce our esteemed panelists, speakers, and guests. But to open this, I'd first like to introduce the chair of this session. The chair is Feng Zhao, the practice manager for the World Bank for the South Asia region. Please give him a warm welcome so he can make some opening remarks.
Thank you, Matt. My name is Feng Zhao. I'm with the World Bank, but I'm also a member of the PMAC International Organizing Committee. So I'm the one who's responsible for designing and organizing and also implementing this session. It has been a journey. The preparation work started exactly a year ago in the last PMAC. We started brainstorming and putting this session together. So as the chair, I'd like to thank the opportunity given for us to discuss technology, innovation, and service delivery, which is really a passion and some topic close to my heart. I will not do justice if I don't thank many people involved in the preparation of this session. It is a collective effort. So there's a few individuals have been working with me throughout the year for putting this session together. My colleagues, Marie-Lise, who couldn't make it because she's moderating another session, another parallel session at the same time. And Matt, of course, is our digital focal point at the bank, who has really contributed. I also want to acknowledge Saida from JECA, who is also part of the PMAC IOC, and also Tim Pastro, who is also IOC member who have contributed. We have an exciting program. So we have, as we speak, Tim just walked in. I just acknowledged your contribution to the session. We can make it a bit informal, right? So this is a parallel session. I'm really looking for interactive and conversation. We have exciting speakers and panels. So Matt will introduce them. But for me, after this formality, I really want to share 3 substantive points, which will help you understand the thinking behind it and a bit background why we organize this session. In the earlier phase, preparing PMAC 2025, we were talking about the scope of the session. Do we want to only focus on AI? We want to have a broader scope, which also focus on other technologies, digital. But eventually we said, we shouldn't be driven by only technology. Our landing points should be on UHC and health system strengthening, because most of us are health professionals. The big lessons learned from the past, even before smartphone, before AI, we also have several waves of the technology movement. Some of you may remember e-health, m-health. That's, when I was in the technical role, I was coordinating the World Bank's e-health, m-health. So the lessons learned from there is we're too much driven by technology. Sometimes we forgot what's our essential purpose is. How do we connecting with the health agenda, with the problem in terms of service delivery in our hand? We're too much into some technology, right? Once you have the hammer, you're looking for a nail. So that's the issue. So I really want to say for this session, we really want to focus on health system and UHC, how this new wave of technology AI, digital, and other innovations, which is really unprecedented magnitude and scope compared with previous technology wave. So that's one thing I want to keep in mind. What solution can the technology innovation we're talking about contribute to the health agenda? Will it help, for example, for Kenya's health strategy, or the bottleneck, the barrier they are facing? So that's one thing I want you to keep in mind. The second one is in terms of the themes. As you can see, this time slot from 2 to 4 p.m. will have 5 parallel sessions, mainly, parallel with the health system pillar framework. So you have session on health financing, you have session on human resource for health. We particularly single out the youth because we feel they are the new generation, they are the voice, they are the future. So there's a session on youth voice, and also there's on data, which my colleague Marlies is moderating. Our session is on service delivery. As we know, service delivery is not a theoretical area, right? So it's a very practical, implementation-driven area. That's why we really want to be practical. We want to share innovation, share different experiences. As you see from the speaker and panel members, we have a quite diverse set of colleagues coming in, share their experience. We really don't want to make this session very theoretical. Let's dive into the practical solution you have found, or the experience you have in your daily work, and just share them. The last point I want to make is we want to make this interactive. Of course, the speaker, the panelists will share their experience, but you also have your innovation. You are working on this. Please feel free when time allows, when there's a Q&A interaction time, please come in, share, use a few, you don't have to make a long speech, a few sentences, or share a link, share some articles, and then we can make this a very collective session, which we can all learn, benefit from this session. That's it. I think my work is already done as a chair. Now I'm hand over to Matt, who will facilitate this session. Thank you.
Thank you so much, Feng. I wanted to briefly take a moment to explain the structure of the session, set a few guidelines, and create the opportunities for engagement, and then set the context before we welcome our first speaker. The session today will start with 2 distinguished speakers sharing some experiences from the geographies that they've been working in. We'll have back-to-back presentations with those speakers. You can give them a brief applause, but I encourage you to take notes and save your questions for a long discussion period that you can address both the panelists and the speakers to learn more about the cases that they're sharing. After the speakers give their cases and talks, we'll invite 3 additional panelists with a wealth of expertise and knowledge in this topic to join the speakers on stage, where we'll have the opportunity to dialogue back and forth in reacting to what the speakers shared, as well as Feng said, take many questions and have the chance for them to react, and we can create a discussion around the topics of health service delivery. Before I take a moment to set the context, just 3 quick notes. Please silence your phones. Do take photos or share or tweet your comments, but do try to keep the audio so that we can respect that. We'll have a virtual panelist as well. So that means if you are participating in the discussion by asking a question, please use the microphone so that our virtual panelists can also be engaged and hear the discussion in the room. And that was all I wanted to say. I'll come and introduce our panelists and speakers shortly, but let me quickly set the context with the chair's slides, if that's possible. I'm sorry, can we go back to the previous set of slides? Sorry to steal your thunder there, Professor Hungao. It'll be just one moment. Thank you very much. So, while the topic is service delivery, one of the key objectives that we really want to see on this, of course, is that technology should also be accomplishing stronger health outcomes if we're applying it towards health service delivery. As Fung said, and there's many sessions here, but there are different elements to the appropriate use of technology in the health system context that might be around improving the access and coverage. There might be resilience and sustainability pieces. There's also the financial efficacy and other pieces. There are many entry points for where technology can play a role in health service delivery. While we won't cover all of these cases today, we'll dive into a few of them that are being shared. But I think many folks know that whether it's in the context of routine immunization, long-term care, the advancing public health goals, or even in the other efficacies that might not be outside of health service delivery, but connected towards inclusion and equity in public health, climate adaptation and how technology can play a role in that, payment systems. There's a lot of entry points for how technology plays a role. One of the reasons that the World Bank is really excited to bring this panel, and I wanted to focus on the word expanding in the session title, is that we will need to scale the impact of health outcomes to achieve the universal health, the SDG targets, as well as a lot more. Now, our own president, Ajay Banga, has talked often about what transformation means, that it's beyond just doing more, increasing the number of transactions. It really is the pursuit of a scaling pathway where we can see a lot of that new. And based on the talks we heard this morning, and I think some of the cases we'll hear today, we'll start to see more around how enabled by technology, applying more of a person-centric in the loop, inclusion and equity, we can build that delivery. The role of development finance institutions, and you'll hear a lot of other financing partners on stage, can really bring an advantage towards scaling that impact. And I think those will be some themes that might come out through the talk of today and something we wanted to share. Now, specific to technology and digital technology, we know there's many folks excited about this agenda here at the conference. There are still challenges. We heard about some of them as well. We heard about some principles and goals that many are working to achieve around equity and inclusion, scaling, targeting the outcomes around universal health coverage and beyond. But within the realm of technology, there are still challenges that we face. Issues around standardization of data, fragmentation, the burden on workforce, as well as the opportunity it might create, or the process of technical debt or change management. The fragmentation of how investments sometimes are made in burdens of disease and technology might not be wide, but addressing specific silos and how we can bring that together. We'll also probably have some talks around what it means for the workforce capacity, especially those working in frontline service delivery. So this is just to acknowledge that while there are many entry points, we have a very optimistic and not necessary outlook around how tech-enabled solutions will be required to get those health outcomes. There are still many challenges within the realm of digital health and technology that we can collectively address together. These were just some of the framing points that I wanted to set before we dive into our first case. So I'm really excited for folks to be here. Once again, feel free to come up close to if there's space available, and take some notes and save some questions as we go on. Our first speaker is Hongqiao Fu, who is an assistant professor at the School of Public Health in Peking University from China. Please give a warm welcome.
Slide, please. Many thanks for your introduction, Matt, and I'm very honored to have this opportunity to share my work about one case of chronic disease management in China. And this work, And this work is about the one case study about the chronic disease management in China. And this work is collaborative with the Professor Wenning Yip and from Harvard University, and two colleagues and from Peking University. And Wait a minute. Okay, and my talk is about the case of Tianjin City in China about the chronic disease management. And this case is the AI adoption combined with the realignment of incentives for primary care doctors. And this work is financially supported by the Gates Foundation, and we appreciate their support. Before I talking about this case study, and I want to give some background information about the China's health system and the UHC progress. And since 2003, and Chinese government has changed its market-oriented health policy and refocused on the financial investment into the health sector. And as a result, we observed a substantial change in the structure of the total health expenditure. And in 2001, the OOP and share in total expenditure is about the 60%. Now it's decreased to 27%. So this means a huge improvement in the equity. And now more than 95% of population are covered by social health insurance. As a result, we observed China's progress in the UHC. And according to the WHO's report, and in 2021, and the UHC index in China is 81, and it is comparable to the index level to the developed countries. However, and we want to emphasize here, and China's progress in UHC are unbalanced. As according to the WHO report, and there are 4 components in the UHC coverage. One is the reproductive, maternal, and child health. And the second one is the infectious disease, and the third one is NCD, and the last one is service capacity and access. And China has remarkable process in the productive, maternal, and children health, infectious disease, and service capacity. And on the right side, you can see many key indicators in the field of the reproductive health, and China's coverage has exceeded 80%. However, there are large gaps in the service coverage of the chronic disease, as there are little progress in the controlling risk factors in the past 20 years. And I will take 2 diseases as an example to explain to you the challenges of China in the chronic disease management. One is the hypertension. And this is a study published in Lancet Global Health. And among the people surveyed between 2014 and 2021, only 44% of the Chinese population are aware of their status of hypertension. And only 34% are under treatment, and only 9% are effectively controlled. So this is a case for the hypertension. And among all the diabetes patients in China, the awareness rate is 36%, and the treatment rate is 32%, and the effective control rate is 16%. So there are very limited improvement in the past 10 years. So this is the challenge for the 2 common chronic disease in China. These 2 diseases are caught quite attention in the government agenda. If you see other health coverage of chronic disease such as asthma, COPD, or the chronic kidney disease, and the effective coverage is much lower than these 2 disease. So this is the challenge for China, and the underlying causes for China's gap. I think the key reason is China has a hospital-centric, fragmented, and treatment-focused health delivery system. And China's public hospitals play a dominant role in China's health delivery system, but they only receive merely 10% of the fiscal subsidies in total their revenues, and they are paid a fee-for-service or case-based method. So they have few incentives to collaborate with their primary care institutions. They also have limited incentives to shift their treatment-based care to the population-based health prevention and management. And for the primary care the sector, and people don't trust the primary care doctors in China because they believe they have no ability, and we often bypass the primary care institution and go directly to the tertiary hospital. And this is the chaos scenario, and maybe in China, and you have 2 or 3 disease, and maybe you have get a mess. So this is one of the underlying causes in China. And so you can see, and with time going, more and more Chinese people going to the tertiary hospitals, and the tertiary hospitals and spend more than 60% of the total budget in the whole country. And Chinese government also recognized these challenges, and they have 2 key measures. And one is to building a tiered healthcare system that promotes the efficient allocation of healthcare resources. Simply speaking, it's just to let the primary care institutions integrated with the secondary hospitals or even the tertiary hospitals. This is one strategy. The other one is the promotion of the new technologies such as the telemedicine or the AI to address the uneven distribution and limited capacity in the primary care institutions. So this is China's strategy. Now let me move to the case of the Tianjin study. And do you know Tianjin? And it's next to the Beijing, and it is located in North China region, and it is also a city directly under the central government. And it is a large city with a population with 13 million people, and 23% are aged 18 and above. And it is also a wealthy city, and it has high level and GDP per capita. The urbanization rate is 85% in 2023. And there are also, because of its aging society, and around 250,000 of diabetes and go to the hospitals or the primary care and institutions in 2022. This is the background information about the Tianjin city. And the Tianjin case, and the Tianjin's case, that there are 3 components. The first component is at the organization level. And like many other cities and counties in this country, and the Tianjin's government lets the 2,066 primary care healthcare facilities vertically integrated with the one secondary hospital, and to form the Digital Medical Alliance. So this is the one change at the organization level. At the same time, and this medical alliance shared the same financial incentive within the institutions, because the Tianjin, the local health security bureau, and implemented the capitation per payment reform with pay for performance. And the first part is for the diabetes patient. And this payment reform is bundle payment for the diabetes patient for all the outpatient expenditures within 1 year. And under this bundle payment, if the medical alliance can save cost by providing better management, and they can share the surplus. So this creates an incentive for the medical alliance to do more health promotion and do more and chronic disease management. So these are the second component of this reform. And so under this organization and incentive change, and the 3+1+N service team formed. And the 3 means that, and they are the staffs from the primary care institutions. They are the public service providers, primary care physicians, and the nurse. And 1 means that the specialist from the secondary hospital, or even from the remote specialist on the internet. And N means are employed by the the secondary hospital, they are the health manager people, and they provide some advice such as the healthy interventions such as the dietary, exercise, and the telemedicine taking. So at the same time, and the third component is about the new technology adoption and the AI empowered and the primary care provisions and the telemedicine network. And the AI aim to enhance the diagnostic accuracy, clinical decision support, and improve the workflow management. And the telemedicine network is aimed to provide the virtual health assistant and also some virtual services between the physicians and the patients. So let me give more details about the AI. Very simply, and at the speaker in the morning, and sometimes we don't need very complicated and technologies. And in Tianjin's case, AI in this stage is very simple. And before the diagnosis, it only covers 5 common diseases: diabetes, hypertension, COPD, and as well as the asthma. And before the diagnosis, the AI will empower the primary doctors and nurses for the intelligence pre-consultation, disease screening, and summarizing the patient conditions. And during the diagnosis, this AI technology will provide recommendations for the diagnosis, test, and treatment. And after diagnosis, and the AI will provide alerts for the irrational medical practice and prescription. I'm not an expert in the AI technology, so I'm not familiar with the technology behind the adoption of the AI. But the company provides this AI, told me, and it is trained by the tertiary hospitals in China, and it overperformed the primary doctors in China and can compete with the doctors in the secondary hospitals. So this is the AI details. And for the telemedicine network, it just address the convenience and for example, the telepharmacy, and once you have the contact with the doctors on the internet, the doctor can prescribe the drugs on the internet and directly deliver the drugs to your home. And the tele-examination to address the uneven distribution of the high technology, some examination equipment. You know, even in Tianjin, a large city in China, and the distribution is not uneven. And the third one is the teleservices, and you can chat with your primary care and the physicians and on the surface, and or sometimes provide some home care. So this is the technology part of this organization, this case change. And we have some preliminary evaluation results. And this is a before and after analysis. We are still working on the difference in difference and rigorous evaluation. And this is a comparison between the data between June 2024 and January and 2023. And for the health outcome and the hemoglobin, the target achievement of the diabetes patients increased from 80% to the 44%, accompanied by improvement in the blood glucose control rate as well as the blood pressure control rate. So this is the improvement in the health outcome. At the same time, and we observed 25% in the surplus from better management. And it equals about the 350 million Chinese yuan. And and as a result, the physician income increased by 50% per month after the implementation of the chronic disease, because the surplus can shared by the primary doctors and as well as the organization, and both the secondary and primary organization. So this is the preliminary results. And this is the first one and the first 2 studies for the Tianjin case. And in the third case, and the Tianjin plan to expand the diseases to the 4 common and chronic disease, including the CVD, COPD, diabetes, and cancers. And it also formed a large regional medical alliance to managing and this chronic disease. And we are still keeping our eye to monitoring the results and outcome of these changes. So this is the summary and the key messages. And in 2022, and Tianjin State in northern China and have initiated an innovative chronic disease management for patients with diabetes and in their primary care facilities, in which an AI are widely adopted to assist primary care physicians and combined with the capitation and pay-for-performance reform. And the early results show that we observed improvement in the health outcome, such as the decline in the abnormal blood pressure and glucose, as well as the controlled hemoglobin target and rate. And we also increased the outpatient service utilization, as well as the decrease in inpatient utilization with a surplus from the payment. So the implication is that such a systematic reform where AI adoption, payment method, and physician compensation method are aligned may be a useful strategy to improve the performance of chronic disease management. As we discussed, the doctors' unwillingness and the resistance are frequently cited as barriers to new technology adoption, such as telemedicine in the early stage and now in the AI area. So integrating AI into the existing health delivery system with realignment of the incentive may be a useful strategies. And this is maybe we can learn from the lessons from other pioneers in China. And many other pioneers in China, they only focus on the adoption of the new technology. And if you ask to the primary doctors and chat with them in the field, they say they certainly use this new technology because they cannot get any financial returns from the utilization. And if you visit them and you can say, oh, the new technology is put on the corner of this room. So this is the lessons from the other partners in China. And I think the case of Tianjin can provide some implications to utilizing the AI technology to build a healthy and world. And this is my presentation, and thank you.
Thank you, Hung Yao. Should you have questions about some of the cases, I encourage you to scribe them down, and briefly after our next speaker, we'll have our panelists and we'll have the opportunity to dialogue about the case shortly. Our next speaker is Umin John. Umin John is the lead for Health Systems Design, Data, and Insights at the Gates Foundation in India. Please welcome Umin John.
Good afternoon. I want to thank the organizers of this session and PMAC for having me here. It's an honor and a privilege to be speaking to you. So for this session on expanding technology-enabled approaches for health services delivery, I'm going to take a slightly different approach of looking at what kind of technologies are available already in the health delivery systems in a context like India. How can we enhance and kind of elaborate it to ensure service delivery. So in the next 10 to 12 minutes, I want to set the context of why we need this and what is the design approach that we have taken, some of the early results, and what are the lessons that we have learned, and what is the path forward. All of us are faced with decisions every day. It could be as simple as, how do I come to this session? Just imagine you were just sent a letter from PMAC organization session and that this session is in Central World. That's all the information that you had. How would you have reached this hall? Quite often, our health delivery systems and our referral systems just do that. So we do screening using digital tools. Frontline healthcare workers are screening people, and then they tell them, go to a primary care facility. They do not necessarily tell them on what days those specialists are available, when is it that they could get a diagnosis, or where could be they can have a diagnostic facility undertaken. Similarly, in India, for the poor and the vulnerable, there are a number of schemes that are available. One of which is the Pradhan Mantri Jan Arogya Yojana, which is India's pathway towards universal health coverage. It covers 40% of India's population. And to avail this, one has to go to a PMJY empaneled healthcare facility. But people who are care seekers do not know where that is. And even if they are referred, if that empaneled hospital is not providing the specific service for which they are being referred, that attempt at getting that service delivery would become futile. There is a cost associated with seeking care, and this opportunity cost, if it is over a multiple number of events, adds up significantly too. So currently, accessing health delivery services really depends on a citizen or their caregiver's ability and knowledge to be able to identify where to go, whom to see, and when to go, how to get care. All of that ownership is on the care seeker. And so what happens is stories like this. Baby Kujur is from a tribal community in one state of India called Jharkhand. The mother, during her pregnancy, had ANC visits, but closer to the term, she started developing some complications. And so her frontline healthcare worker asked her to go to the ANC clinic, and there she was examined, and it was identified that baby Kujur was having fetal distress. And the intervention was an emergency cesarean section. So she was referred by the frontline healthcare worker to the first referral unit, or where she could have had the emergency cesarean section. This was 35 kilometers away from this person's home. And when this mother was examined at this hospital in Gumla, 35 kilometers from their home, they were told that we are not able to manage your baby and your delivery here because it's likely that you will need neonatal care and perhaps an ICU. And so they were referred to the nearest government hospital, which is about an hour away at Lohadaga. So the mother and husband went to Lohadaga, and when they reached Lohadaga, they had the emergency section, and because the baby was in distress, they were immediately referred to the regional medical college, which is a 3 hours and 20-minute drive. And while on that ambulance to the medical college, the ambulance driver told the parents that your baby cannot be managed at RIMS, and that the ambulance driver has been told to go to a private hospital, which is again another half an hour away. So at the private facility, while they were eligible for this PMJY or the government insurance program, an additional 21,000 rupees in Indian rupees was asked for. They had to borrow from somewhere and make that payment and get admitted. They were in the hospital for 4 days. After 4 days, they were told, please leave from here and go to another hospital in Ranchi, again half an hour away. And on reaching the other hospital, baby was there, put on ventilator, and died in a day. So this is the journey of the poor and the vulnerable, not only the poor and the vulnerable, and many of the people who do not have ability to navigate the complex health delivery systems that our health delivery systems offer. So how can we go about this? So this is a recent review that looked at about 100 infant mortality cases using a verbal autopsy approach to identify what are the factors that are responsible for death. So low birth weight, number of children that have been born before that, large size families, education of the parents are all factors that affect infant mortality. But besides this, one key factor is the identification of a complication and the time it takes for seeking care. So if there was a level 1 delay, up to 24 hours, the mortality rate significantly rose. And as you can note here, there is referral to another hospital, referral to another hospital, referral to another hospital. And as you see, as you go up the referral, number of referrals, the mortality rate is almost like significantly high, exponentially high. Like I mentioned earlier, if the median delay was for the level 1 care was up to 24 hours, the mortality in those cases was as high as 40%. So that was not only for mortality. The complication in care seeking is not only for neonatal cases or for infant mortality. This is a study from India, again, that identified people who had cancer from the time they had initial diagnosis of cancer from the initial time they had symptoms of cancer to the time they were diagnosed or when they had a formal appointment. The average number of days was about 180 days. And if you were to observe the time that it takes for a woman, just because you're a woman, you had a 3 times delay in having the first consultation for your cancer symptom as compared to being a male. When we talk about equity, we have to also see what are the pathways by which our health delivery systems can address existing inequities. And again, as the stage of cancer increased, the delay in the time from symptom to the time to consultation is very high. This is quite contrary to what we would think, right? When you have visible symptoms or symptoms that are affecting you, you would seek care earlier. But that's not the case. So what did we do? We undertook a literature review to identify what are some of the constraints that are there. So what we identified that there are definitely financial constraints, there is variability in service quality, and there is low satisfaction. There are challenges around geographic accessibility. The systems are complex to navigate, and there are several challenges. There is no awareness of the existing facilities and availability of the appropriate services. So as a next step, we looked at how can we address this information asymmetry and make it available for citizens who are wanting to seek care, and how can we use existing systems, because putting together a new system would be very difficult. So we recognize that there are a number of health helplines that are available in the country, and what if we took one of the helplines and used a mechanism of using these helplines to have care seekers call in there, use an AI-powered adaptive question engine to support in identifying what is the potential diagnosis, not giving a clinical diagnosis, but a potential diagnosis, and what subspecialty or specialty should they be referred to. And through doing this, through the adaptive question engine, the beginning of an electronic health summary, or the beginning, if they were able to have a digital identifier generated, then an electronic health record was generated. Then, based on which geography they were calling from, it was possible to identify which facility had availability of those services and provide a ticketed appointment. By giving them this ticketed appointment, there was an assurance of service delivery and some certainty in the journey of health seeking that could be brought into The third thing, that for every case that was logged with a complaint, there was a follow-up mechanism by which whether the care was delivered or not. And the call center would do follow-up calls to understand service fulfillment or otherwise. This has been used extensively in some of the states for improving maternal outcomes. So again, a case study. This lady had symptoms of preeclampsia, and she, along with a frontline healthcare worker, coordinated the care coordination center, and that adaptive question engine was used. Preeclampsia was identified, and using the service inventory, a facility with availability of the doctor was identified, and with coordination of the ambulance delivery system, the person was able to be taken to the hospital, an emergency procedure was done. So through just getting a call facilitated by a frontline healthcare worker, this mother's life and the baby's life could be saved. Not only did it stop there, after the delivery, the electronic health record allowed for the baby's record to be also created, and triggers for the vaccination and follow-up for that could also be done through the care coordination center. So, like I said, in the short pilot that we did in Madhya Pradesh, it reduced the time to seeking care in this very small pilot from an average of 8.1 days to about 4.7 days. And this is very gross measures of out-of-pocket expenditure, but it had reduced by a small percentage. But 40% of people who would have otherwise gone into the informal sector or to the private practitioners in the absence of a helpline were actually sent to an accredited facility. And 45% of people who would have otherwise gone to a district or a secondary, tertiary level hospital were actually directed towards a primary healthcare center. So just imagine when a large number of people with common conditions such as diabetes, hypertension are actually being diagnosed for diabetes, hypertension at a district hospital or a medical college. It is a huge inefficiency in our service delivery. What if we can, through this triaging mechanism, actually ensure that it's not only task shifting, but also task facilitation by ensuring the primary healthcare facilities and the community health facilities to be able to diagnose these and manage these conditions. So using these existing helplines and through this AI adaptive question engine, we have been able to give ticketed appointments, and using the symptom checker and the EHR generation, we've been able to generate longitudinal health records. As of now, 113 district government facilities have been empaneled, and 400 physicians across 23 specialties are available. And it gives us real-time ability to see where are the facilities, what is the availability of appointment slots, and direct patients towards that. So in a nutshell, by this simple technological intervention of using an existing call center, an adaptive question engine, and using a triaging mechanism facilitated by a call center, the service availability is become discoverable, and a scheduling appointment that will be fulfilled with giving certainty in the patient journey has been possible to establish. In the interest of time, I'm just quickly go through the early results. And in the 9 months since, we have seen significant increase in the number of calls. And as you can note that sometimes it's the health worker who is making a call, and they take multiple appointments, and therefore the mismatch between the number of appointments provided and the number of calls. And one of the key learnings from this is that through this triaging function and a gatekeeping function, ensuring that those who need lower levels of care are being able to give that at the primary healthcare center facility. And appointments have seen a fulfillment rate about 99% over the period of time. And over the period of time, we've also significantly reduced the waiting time. And 22% of the helpline users are returning appointment seekers. I'll quickly go back to so reimagining the journey for a baby like Kujur. If we had a mechanism by which this particular case was coordinated through a triaging function and a secured appointment and a facility where this baby could have been operated upon was given, maybe this baby could have been saved. So what does it mean for governance? So what if our health delivery systems adopt a digital-first primary care that enables real-time monitoring, like every flight? What if a health worker is able to view her population like the metadata that a flight radar has? It knows where a flight is supposed to land, what is the estimated time of arrival, and all one needs to do is to monitor the reds, the deviations, and consistently, if the worker, their manager, and their supervisor are able to reduce the number of reds week on week, we will be able to ensure a more accountable delivery system. Thank you.
Thanks very much. We're going to transition to the second portion of our afternoon session here, where I'm excited to welcome our speakers back on stage, as well as some panelists, which I'll introduce momentarily. We'll take a moment here because the discussion will switch to the wonderful chairs that we have out on stage. We also have a virtual panelist joining us that we'll be putting on screen momentarily, and I'll introduce. So first, let me please welcome Hong Kiao and Uman back to the stage. And I'd like to introduce three more panelists. First, online, we have Nanjira Sambuli. Let's see if we can get them present. Nanjira is the non-resident scholar of technology and international affairs at the Carnegie Endowment for International Peace and dialing in from Kenya. She comes on screen momentarily. We'll be able to say hello. I will also introduce Rahul Malik. Rahul Malik is the Senior Vice President for Digital at Resolve to Save Lives, visiting from India. And we also have Ms. Yuko Agata. Yuko is the Chief Operating Officer at Melody International, a telemedicine firm coming and visiting from us from Japan. Please give a warm welcome to all of us that are joining on the panel on stage. And we see you, Nanjira. Thanks for being here. I'll be joining you shortly on the couches. Please have a seat. And just a friendly reminder, let's all try to use the microphones so that our colleague Nanjira can hear us and participate. What I'd like to do is, since we had two excellent cases from Hong Kiao and Uman, I'd like to give the opportunity for the three panelists to also spend 3 to 5 minutes to share your own perspectives on this journey around expanding technology-enabled health service delivery. You could use the time to react to what was shared or bring up some of the key themes. If you don't mind, I'd like to start with Nanjira online, if that's all right. Please go ahead.
And I hope you can hear me okay.
Yes.
Great, wonderful. Just building on the presentations we've had, I want to reflect on just the bottlenecks that tech can and cannot address in health service delivery. And I want to draw from the example of Kenya that may have even already come up in the conference. And this is the intervention by the government health service at community level, which has long been a challenge in the country and I think in many other jurisdictions. We have a situation in Kenya currently where the community health promoters and community health workers, rather, have been recruited en masse to help bridge between health facilities and communities. This incremental approach has tried to leverage both technology and the sort of human interfacing component, which I think is really, really critical in thinking about tech and health service delivery. The community health promoters are numbering about 100,000 now across the country. Their primary role entails disseminating vital information on nutrition, hygiene, and general disease prevention measures in villages and communities across the countries. They're usually equipped with emergency kits that contain a first aid kit with items like a weighing scale, a blood pressure monitor, clinical thermometer, and the like that help them, and simple drugs like pain relievers. They're also equipped with a smartphone through which they're able to collect data that is instantly uploaded on what is called the electronic community health information system. And here is where the AI component comes in, where this data is analyzed and aggregated in real time to facilitate reporting on community health activities and outcomes. The system is interoperable with other health systems in the country, and through a secure data exchange mechanism allows health workers and managers at all levels of the health system to access the appropriate level of data. The system is designed in a way that the community health promoter at the point of interaction is taken through a comprehensive evaluation checklist in each household that they visit, and it issues alerts as they go along through the checklist in conversation with the clients to issue alerts on probable disease cases such as malaria. And this system will then share information with a nearby health facility where the patient will present a referral card that has been put together by the health promoter, and their medical history will technically be available once they arrive at the health facility. Additionally, the health promoters can send messages to households in advance to help prepare for their visit, and they can also, have follow-up messages. This model where algorithms and AI are sort of introduced in the middle has notably improved the quality and timeliness of data collection and reporting, which in turn is supposed to help inform decision-making and resource allocation. And evaluations in specific geographies have shown that the data and this tech-driven community-based healthcare has really improved coverage of the leading causes, for example, of child mortality in the country. Additional benefits have been the improved skills and competency among the health promoters, and this interactive system and helping through algorithms and real-time guidance has enabled them to make better clinical decisions, track patient outcomes, and ensure accurate reporting. Now, it's very important to emphasize that the success of this model has been the combination of the social and the human component with the technological to deliver contextually beneficial health outcomes at the grassroots level. Here, it's very important to think about this because affordability, availability of devices and internet is still not necessarily ubiquitous at a community level. And this interaction is a crucial node in bridging that gap. Now that the model is being scaled across the country, and is continually being evaluated, we now face the headwinds or the bottlenecks that perhaps tech alone cannot solve. First is to recognize that this system is a success because it's a culmination of a decade of investments in community health digitalization in the country. Often in the development sector, we tend to have pilot projects after pilot projects, and we end up stuck in what I call pilotitis. But this has been a really important model that has tried to bring the disparate components together to move towards really intervening at that community health level. And there are comparable systems that are now being deployed in about 6 other countries in Africa and in Asia. But here are some of the things that the tech alone cannot address. The bulkiness of the kits that these community health promoters work with is already come up. And it will be very interesting to see if and how the consortium that manages this system is able to quickly adapt to this, because this could discourage the community health promoters from continually signing up and doing the best possible work. Issues like timely remuneration of the community health promoters have been coming up as a significant bottleneck. The personal safety of these promoters when they move through disparate communities and the mental strain and toll that their work has is important as another consideration that the tech alone cannot necessarily address. Now, this is a collaboration between the government and digital health NGOs at a time where aid and development resources from the multilateral system and bilateral donors is being disrupted. And this is going to present interesting challenges ahead insofar as how this system is continually improved. However, here is where there's an opportunity for the government to work with local tech ecosystems to actually have localized development and continual improvement. This is something that we're hearing in broader strokes when we talk about open source and modular platforms that allow for innovation, and how this model can really present itself in the continued use of such a system. In sum, to say that the success of this model, its scaling and sustainability over time, is going to be determined by the political challenges, the social political challenges that exist, where technology is not necessarily an intervening factor. And this is often very important to think about when we're talking in these conversations, because we tend to focus too much sometimes on the tech and forget about the social, political, and cultural environment. So it is an interesting moment in Kenya to really take stock of where tech can and cannot help, and how those two things can work together towards delivering universal health coverage goals in the country. Thank you.
Nanjira, thank you so much for your opening remarks. You're getting a warm, big applause in the room of everybody that's impressed. And to share the story of the electronic community health information system, the journey for what it means for community health in Kenya and the African context is extremely valuable. For the next set of our panelists' opening remarks, I'd like to ask Rahul Malik to share some perspectives either from your organization or the reflections on what you heard from today.
Thank you very much. I don't think I need the step. I'll manage without that. I asked one of our good friends, ChatGPT, that I'm presenting at an event and which has very distinguished audience. How do I keep them away from their phones and devices while I'm presenting? Well, I've got some good tips. Start with a hook, make it interactive. Use minimal visuals and text. Move around and use dynamic voice modulation. Maybe I could do that. Acknowledge the distractions and time it well. So I've got 3 minutes. That's what Matt's given me. So I'm certainly going to keep the last one on. Health service delivery is an important role for a health service provider. And there are two truths which we have seen, and I've seen in my work for the last 12 years in digital health, which hold true in any country you might be in any public health system you might be working. When you go to a frontline worker or a health facility worker, there are two things they will tell you. I didn't come to work just to enter data. I came to help patients. That's the first thing they will tell you. And the second thing they will tell you, if you could, I could do it myself. I'm already busy. Please don't make my work harder. When we look at digital tech for service delivery, sometimes we forget to look at the perspective of the people who are actually going to be at the forefront of that service delivery. And that's really, really important. All the work which I have done in my time in digital health, this has been the most important perspective I've seen. We had great presentations. Dr. Fu spoke about technology innovation using AI, the amount of results they could get around HbA1c control. Great examples. Women spoke very well about the challenges of access to care, and something as simple as triaging using calls could actually save a lot. Fundamentally, my personal belief is you could use really simplistic technology to actually make a lot of impact, QR codes being one of them. And we have seen that. By the way, this QR code, if you scan it, will take you to a playbook of how do you use and design effective digital systems for hypertension control. It's a very good resource for anyone to have. Service delivery bottlenecks, we all know, fall under few areas. High patient volume, extremely long wait times in many places, shortage of staff, very high burnout, inadequate infrastructure in some places and resources which are there. You have supply chain issues, and you have poor health information management. Getting a patient back to care is the single most important thing you can do in a healthcare setting. We had, I think Dr. Fu showed us about 27% of OPD patients still go to tertiary care, and that might end up putting a lot more pressure. If you were to bring patients back to care at primary care with effective use of tech, you would be able to put lesser pressure on the remaining system of your healthcare environment. So this is just an opening remark from my side. I'm looking forward to this conversation. There have been some great speakers already, and I look forward to engaging with you. Thank you.
Thanks, Rahul. Also, some well-received applause from the audience. And finally, just to finish the opening of our panel, I'd like to introduce Yuko, who wanted to talk about some of the other roles that telemedicine can play in the healthcare systems.
Yes, thank you. Thank you very much. Hello, everyone. I'm Yuko Ogata. Thank you. CCO of Melody International. Nice to meet you. It is great honor to be here. And I'd like to talk about the social issues I aim to solve. One key success was when I miniaturized the fetal monitor. This invention was even used by Queen of Bhutan and resulting in the healthy birth of the prince. A profound moment. What do you think this figure shows? Every year, 140 million mothers give birth and 2 million babies during delivery. Why is this happening? A shortage of doctors and limited checkup, each high maternal and child mortality rate. The chart shows higher mortality rate, especially in Africa, India, and Latin America. Pregnancy and childbirth remain very risky, but we have solution. Fetal monitor can be reduced. Since 1974, when our professor invented the old fetal monitor, these mortality rates have dropped significantly. This slide, we developed Melody AI. We developed a Melody AI and communication platform for pregnant women and doctors to optimize the medical resource in reduce the fetal monitor ICDG, allowing mothers and consult doctors online. And if concerns arise, in emergencies, she can be smoothly referred to a larger hospital, preventing this hypoxia. The core technology of the fetal monitor ICTG are smaller medical device using remote communication technology. It's lightweight, wireless, and easy to carry, yet offers the same performance, high performance as conventional medical equipment. 3 types of perinatal health only the fetal monitor ICTG can provide. First, referral case. Transfer of the referral to the core hospital based on the remote specialist diagnosis. Second, home use. Receive advanced medical care at home to peace of mind. Third, ambulance use. Remote fetal monitor during emergency transport, the core hospital, allowing obstetrician to prepare for the next operation. In Chiang Mai, Thailand, about 30 public hospitals lack obstetricians. By introduce ICTG to these hospitals, a legal system was created. Allows remind doctors diagnosis pregnant women in the initial clinical trial. 1,500 cases was measured with ICTG, saving babies lives through timely treatment to C-sections. As a result, Dr. Spatola in Chiang Mai University received the Best Public Service Award from Thailand Prime Minister in 2017, leading the widespread of the ICTG of Chiang Mai. The ICTG referral system introduced 80 hospitals in 20 districts across the Bhutan and in use of the even larger hospital system in Bhutan. Instead of OBGYN operated the device of the diagnosis remotely, and nurse or general doctor uses the ICTG. We are committed to the further improvement of the perinatal care level in the world, from Japan to Africa. Thank you for your attention.
Thank you, Yuko. Well, thanks to a great set of speakers where we heard cases from all around the world and different entry points and a selection of specific health service delivery bottlenecks that technology is already starting to be applied and changed. I'll start with one question to the panel, and while I do this, I encourage those out in the audience to take some of the notes that you might have taken from the other panels, prepare a question, and if you do have one, please feel free to come to the microphones and we'll try to take them maybe 1 to 2 to 3 at a time. You can address them to any panelists or the speakers, and we'll try to collectively do that through the remainder of our time in our discussion today. So as the audience wakes up from our lunch slumber and digests some of the amazing stories of technology that we heard today, let me bring it back to this question of some of those service delivery bottlenecks. We heard some quite interesting ones. The challenge is that even with ECHIS in Kenya and Nigeria, of how community health workers still have a large pack that they have to carry, and they might not have visibility into what happens into a referral. The very tragic story of baby Kujur, who, because of time and access and geographies, that was a burden on being able to present for care at facilities, or even the bottlenecks of the pressure to do the burden of reporting or working harder. I was wondering if I could ask maybe Rahul to start on, are there any other bottlenecks that you think we haven't talked about yet where you've seen technology play a role, and particularly where maybe it's been applied to work at scale, like some of the community health work we heard across the nation of Kenya or across many, many providers in the nation of Bhutan, like you were talking about. Yeah. Please.
Thank you, Matt. I think as I mentioned in my opening remarks, getting patients back to care is an extremely important function of our healthcare system. Sometimes there are tools which you can use. You can send them SMSs, you can have follow-up calls with them. Predominantly, you need to use the tech which works the most for the environment you are setting it up for. We've done studies to even understand that if you send a patient a reminder 2 days via an SMS for their appointment, which is 2 days hence, versus if you send it 1 day in advance, or if you send it on the day of the appointment, which of them actually get you more likelihood of them returning to care? You constantly need to test which are those ways in which you can get patients back to care. So for me, one of the biggest service delivery bottlenecks is that if patients don't come back to care, you don't have longitudinal records of patient care, and then you can't make sure that they are getting the right kind of treatment. So that's something which technology, if it can solve, it's simplistic, that's fine. In any form or shape, if you can solve for that, that would be really, really important.
Thanks. Najir, maybe I can go back to you. You already shared so many of the burdens that some of the community health workforce faces. What else haven't we talked about yet that are other key bottlenecks and maybe where you've seen technology make an impact?
Yeah, I'll speak to two again, just drawing from the Kenya experience. One thing that I think of often is when we introduce tech systems and they take on the role that somebody was doing, where that person is displaced to matters. And one bottleneck that could be an unintended consequence is if they are still within the system sort of floating and they become a friction as a person because they want to hold on to, say, the job, the tenure, and thinking here of so-called back-end officers who still matter in the healthcare ecosystem, who, the tech can now do the collating. Happens to health clerks, where really matters. And the other is just even like what we're seeing in Kenya currently, where the entire health insurance system has been overhauled in the name of digital. And because it's not been adequately tested and has not necessarily improved on the existing system that was, it is risking leading to distrust that the moment you say you're doing something digital, because these glaring outcomes and harms are being seen, you then have people starting to distrust anything that is done as digital. And this is a significant bottleneck that we can expect to see going forward. So I think these are two very important ones. Just showed that the technological is very much political, and I think we must not lose sight of that fact.
No problem. Thanks, Nigeria. I'm actually very grateful that we have our colleague Saida-san, who might support our colleague Yuko in dialoguing with us in English. And so I'll invite them to the stage, and just thanks for your opportunity to participate. Just in case you wanted to support each other. And so again, thanks, Nigeria, for that brief pause, and it's well acknowledged. Yuko, I wanted to offer you shared already the specific health service delivery bottleneck around with maternal and child health. Is there anything else you wanted to talk about specific towards that health challenge, or possibly the role the private sector plays in addressing some of those service delivery bottlenecks?
.そうですね。私は、ここの中で唯一の、プライベートセクターです。それで、ボトルネックになるものはたくさんあります。そして、主に4つのものがあって、規制、そして、データの、連携、それから、公共自治体とかとの連携、公共との連携ですね。そして、世界拡張っていうか、世界への展開。この4つのものがあります。
Okay, she's just only one presenter from private sector, and from that point of view, she recognized 4 bottlenecks. One is the regulation issue, and second one is data linkage, and third one is the relationship with the public sector, and the last one is the scaling up or how to expand the product to other countries.
Thank you so much for sharing that. Actually, you've opened up a whole new door around the policy side.
Yeah, thank you.
What regulation might play a role. That was brought up in our opening keynotes this morning too of our colleagues around what are both policy and governance issues. So maybe we may explore some of that, some of our other questions. I'll make one more call to the audience. If you do have any questions and want to engage with our panelists, please present at the microphones and we'll be happy to take or cue your questions as we continue the discussion today. You brought up the... Oh, Samil in the back. Yes, please.
Thanks,
and please, sorry, since you're the first from our audience, please state your name and your organization with the question. It'd be helpful for those online and on the panel.
Thank you. I'm Somil Nakwal from the World Bank. Matt, very good session, and thanks to all the speakers. on this very important topic. Now, in the last 1 year, a lot of people, including me, have been very scared that AI will take away a lot of the jobs that we currently do. And I think that's something that our Kenyan colleague was also reflecting. But the nature of job itself will change. And how do we see the new jobs that will emerge? Particularly, I think, in service delivery, we may be looking at a digitally enabled tech worker who is going to be able to do much more in a peripheral setting than was currently possible. So while the traditional jobs may be threatened, a new range of jobs would be emerging. And I think I would be very keen to see how we see service delivery as being uplifted and jobs being uplifted and not being lost with this new phenomenon, all resulting in improved access as kind of the glass full story of technology. Thank you.
Thank you, Samil. An excellent question. I've taken some note of it. We have one more in the queue, so let's take both, and we'll go to the panel to respond to each of these.
Hi, thanks so much. Excellent panel. I'm Catherine Shelley with PATH. I wanted to hear a little bit more about the role that these tech strategies can play on the quality side, and specifically was wondering, Dr. Uman, how quality might factor into the referral triage. Sometimes patients tend to have a good sense of which facilities are higher quality, and maybe also quality might factor into where patients get sent for certain conditions if they have availability to manage those. So just wanted to hear your reflections on that. Thank you.
Thanks so much. I'll route the first question to Dr. Uman, since you've been patient while our panelists speak, if you want to respond to that. And then I know panelists will probably want to respond to both that and Samil's prompt as well.
Thank you. So to understand quality, we need to know what the baseline is and what the outcomes are. In the absence of electronic summary of that transaction, it's not able to do that. So what we have been attempting is to develop that baseline of the clinical characteristic through this AI-enabled adaptive question engine. And it is a huge incentive for the insurance sector as well, because one of the biggest challenges that the insurance-based health service provision is fraud. Fraud by healthcare providers. So, but if you have established this is the set of symptoms through which the diagnosis has been made, and it is adhering to the standard treatment workflows. The other is, once you have an electronic health record that is established, the prescription, the adherence to that, and outcomes help us to understand quality. So these are two measures. So the beauty of the low touch tech that we are using is that all of the complexity of the technology is behind the scenes. To a frontline healthcare, it's just a phone call away. To the person who's manning the call center, it is just a few questions that is actually prompted by the heavy lifting by the AI engine that is doing. So keeping technology simple, as in the interface simple and complexity behind, is one way to do that. So we hope that by the end of our work in Madhya Pradesh, we would be able to actually come up with a dashboard that signals quality through outcomes, and then this informed choice to the care seeker is based on that quality indicator. Thank you.
Thank you so much. Maybe Yuko can go to you next on both questions. The second one, which was around quality and accountability and the implications on jobs or workers.
Second question, okay? クオリティの方ですよね。はい。クオリティに関しては、私たちが開発した機器は医療機器の認証を取っています。各国で取っていて、安全性と品質を保っていて、診断精度も正確です。
The Melody's ICTG is approved by the government authority, country by country. So it is the quality is assured, and the correct it is very precise.
Thanks very much. Now let's try to answer that first question that came in about the implications on workforce or what that mean about the next generation of jobs or how jobs might be changing. Angira, if I could pass back to you on, you talked a lot already about the community health workforce. I'm sure it still has massive implications for what that burden might be or what the next set of tasks or challenges that need to be met from the question that we heard in the audience. I'd welcome your thoughts on that.
Sure. And I'd start by saying I think it's going to be very important that even as much as we want to think about the scale level implications of AI in the workforce, that we look at it context by context, because often the sort of idea that one size fits all can really have us lose a lot of insights here. I think, for example, ideally, how do we ensure that whatever is introduced as tech or AI or anything else to strengthen service delivery really serves the aim of releasing humans to do better human work? By that, I mean, how do we have humans do a better job of being caregivers, sitting with, whether it's a sickly patient for conversation and such. And I was thinking of an example of AI health, preventive healthcare I read about in Singapore, where because of a shortage of nurses, some bots have been introduced in elderly care homes to help, the elderly sort of play games and even more interestingly, record their life stories. And it's very interesting to assess where humans then fit in that model, where some typical work that has been done by humans has already been sort of automated. And what that will look like differently to, say, a region like Africa that has predominantly young people who are going to need jobs, even as we digitize, and how we can see, and just really bring a nuanced understanding to what we mean by introducing machines in the age of intelligence into spaces and places that humans did a job, not necessarily to replace them, but to elevate them to doing a better job. I think this is going to be a critical determinant about how we frame the questions and the analysis that we do, and more importantly, how we allocate resources towards the improving service delivery.
Thanks very much. You've got plenty of nods in the room as well, I think, agreeing with that. And Rahul, your opening remarks already centered the workforce at the beginning around what it might mean, and I'm sure you probably have quite a bit to share on what it might mean for the next generation or the changes in job profiles or beyond.
Yeah, I think the health workers are really looking at tools which make their jobs easier, and if there are AI tools which enable them to, make their life simpler, they would be more than happy to use it. My general sense is that there are a few areas where we could potentially see more growth in terms of making it easier for them. One is their training and upskilling. I think that's one area which is a constant challenge, because many of them, there's a low digital literacy in some cases. Their ability to get answers to questions which they might have, because the kind of protocols and standards which they have, if you, I'm sure most of you have gone to a health facility, if you really see the protocols and standards for each disease area, which are pasted as big charts on their health facility, those are not the most user-friendly for them to look at and consult it. AI can really make a huge impact in making that much simpler for them. There are definite use cases where complex problems which they see a multi-symptomatic patient, they do not know what line of treatment or what advice they would like to give. That's where AI could really play a role. So I do think there are many use cases, but there are some real fundamentals for it to happen. One, it really has to have a very strong data foundation, whatever AI you built on it, that's really essential. It has to create the most relevant and scalable use cases. If they are not really relevant for the health worker and it's largely systemic, then they might have an adoption issue. If it's not scalable, then we also know that won't really work for you. And finally, it has to be really trustworthy, because if they're going to give any advice on any medical matter, that advice needs to be very trustworthy. So yeah, these three would be key foundations to building anything on top.
Thanks. I'll take the opportunity to start a new thread in this conversation and link it to some of the opening context remarks. I think it builds off of this, which was, how do we scale or expand? We've talked around what maybe the next big barriers might be in the changing on the workforce, assuring the quality, continuing with the evidence. But inevitably, we have to continue to scale to get the outcomes that I think we're all expecting. And so maybe kind of in reverse order, I'll go back on specifically, what are the means or the challenges in replicating these success stories many times over, not just transactionally, but achieving this transformation, which is the theme of the conference, or scaling it to a whole of population or community impact. And I wonder if folks would be willing to share their thoughts on, well, how do we take what's working well and go to scale?
Let's start.
Yeah.
Sometimes I call it the seduction of scale. We want to think that everything necessarily needs to be scaled, but we have to first think what's working and what's not. Typically, I've seen that the technologies which work the best are the ones where the users are most interested in using it on a continuous basis. And that's the one which has to necessarily be a prime candidate for scale. And of course, it has to support your health outcomes and what it gets to do with the health outcomes for patients and community at large. I do think that the sustainability and the scale question also has an element of governance and policy, Matt, which we briefly discussed. Oftentimes, and as everybody in this room would vouch, that you have too many systems which are operating in countries which are very much fragmented. And in the absence of a strong governance and policy framework around that, it would be very hard for any system to be sustainably scaled. This governance and policy is also essential for you to have the right kind of a digital ecosystem set up in the country, because in most countries, you have a separate payer, you have a separate provider, and then you have a national public health institution which is responsible for standards around clinical protocols and treatments. All these three have to come within the gamut of that larger digital ecosystem and strategy. Like we've seen examples of national digital health agencies which can do that. So yeah, I'm just kind of also linking up and probably helping you also move into one important topic which you heard in the morning around governance and policy and how that links back to scale.
Thanks. Yuko, can I ask you if you wanted to talk about you brought up the governance and policy first on this panel, and we'll tagged it again.
Yeah.
Whether it's about scale and expansion
Yeah.
or the role of this policy, did you have thoughts to share on either of those topics?
はい、一言で言えば、私の危機は病院の中、そして医師が使うだけでなく、今まで医療機器は病院の中で医師が使うものとしてありましたけれども、病院の外に出したことによって医師でない看護師さんや助産師さん、そしてジェネラルドクターが、使うことができて、それがスケールアップにつながるというふうに思っています。
The equipment of Medical International is originally CTG was used in the hospital and with specialized medical doctor. But this equipment was modified to use outside the hospital and used by the general practitioners or nurses. So it could it enabled to scale up the utilization.
Thank you so much. Can I probe the second question about on the policy or governance side, from your perspectives in the private sector, what will make it easier for the market to participate or continue to grow and scale?
Yeah, thank you. やっぱり私たちは、これを進めるためにはパブリックセクターの協力が必ず必要です。それと、やはり今までの医療機器の販売とは違うところに持っていくために、いろいろ資金とかも必要となります。資金。それは、そんなに大きい資金ではないのですが、必要です。その2点。
Okay. To promote, she recognized that the collaboration with the public sector is very, very essential. And the second one is the private sector have to find out the market, new market, and to go into that area, the fund support is necessary.
例えばブータンでは15人しか産婦人科医がいないんですが、国全体で医療、この赤ちゃん、お母さんと赤ちゃんの健康を見守るということを始めて、モータリティレートが減ってきました。
In Bhutan, there are only 15 OBGYN doctors, but as a national program, this equipment utilization was scaled up nationwide.
それは保健省が協力してくれて、母子手帳にもこのICT を使うっていうことを入れてくれた。これが、うまく働いたと思っています。
It is because of Ministry of Health Bhutan's decision making.
Thanks for sharing those perspectives and the example of Bhutan, where we're in a situation of only 15 OBGYNs, and you could use technology. Leadership of the public sector and the ministry can help with the scale. Let me pass to Nanjira and then also our speakers to comment on this too. Whether it's this concept of what should be taken to scale only if it's well, or actually the other non-technical factors, the policy or the governance implications that needs to come into play, whether it's your perspectives in Kenya, Africa, or working in community health, would be keen to hear more.
Scale is my favorite topic in tech because it's a question not just in health, but in all aspects of digitalization. I like that Rahul called it the seduction of scale because we tend to think of it as if it works here, surely it can work everywhere. Let's find where else it can work, rather than what works and how can scale then be redefined as what is interoperable based on different disparate things that work in different contexts. This is because there's politics to scaling that is defined by whatever incentives, whether it's the development sector thinking about we want to have a pilot that scales for 5 years across different countries, but we want to have public-private sector collaboration. But is the private sector that is going to be involved in Bhutan the same private sector that's going to be involved in Kenya in a similar program? Where do we introduce those avenues to really, make it normative and contextual? This remains a missing link in much of digital development. And I think we have to have more conversations really as corollaries around this idea of scale and what we're really going for, because it's fundamentally political.
Thank you so much for sharing that. We'll probably have time for 1 or 2 more questions from the audience too. So if you do have a good comment, please line up at the microphone. But I'll pass the same question to both Hongkiao and Umin. Both of you shared examples of a specific journey of a patient or a specific burden of disease, but you're coming from context where the health service delivery network has to serve millions, if not tens of millions, hundreds of millions of people. So the policy arm can be huge. Based on even the evidence in the cases you shared, or thinking much bigger on the policy implications, I wonder what you'd like to share or contribute with the group here today.
Thank you for your question. And I think there are three questions we need to answer during we scale up the new technology to the whole population. And the first one is who pay for the new technology. And this is very important because financial sustainability is very important for private and companies, as well as the people who run the startups. So in China's case, and the health security offices are reluctant to pay for the new technology sometimes, and because China is rapid aging, and it is also to face the debate of the health insurance themes. So who pay for the technology? I think one of the China's strategies want to rely on the commercial insurance, as well as sometimes the social insurance will pay for it. But the share of the social insurance maybe is is smaller than the commercial insurance. And the second question is who will regulate the new technology, because the AI and telemedicine is a double-edged sword, and how can we to push the AI technology to serve the people health rather than a tool for make money? And I think this is very important for scaling up. And the third question is who are responsible for continuous development of the new technology? Because we are not in a stage that everything remains the constant, and we need to develop the new technology. And so a environment that encourage such the development of new technology is very important. For example, in China and many local governments and create a very friendly business environment to the startups to encourage the new technology development and by reducing the tax and for the startups. So I think these three factors are very important for the future and the scale up to the whole population. Thank you.
Thanks. I wonder if you briefly wanted to comment too before we take our questions from the audience.
Just briefly. I think when we think of scale, especially from the Indian context, we have a large number of healthcare workers who are on the front lines and enabling them. So we've seen task sharing, we've heard of task shifting, but can our technologies, particularly the emerging technologies, help in task enablement? One of the things is things that would give credibility to frontline healthcare worker. So if she makes a referral, if she's assured that her word is actually credible and she has more credibility because our technologies are enabling her to serve her populations better. The other is observability. So when we have data that helps her prioritize her workload, not only just workload, but which are the ones, if she does not act today, that will have a disastrous consequence. Can we use the same concept of triaging, but at a very nano scale, in the hands of each of them? So basically, the AI technologies allow federated learning. Can we pass this federated learning into the hands of these extremely helpful and dedicated, motivated, underpaid workers and help them to deliver better? Then it will naturally scale.
Thanks for sharing that. And thanks for your patience. Please, I'd like to invite some more questions from our very patient audience. And please share your name and your organization or what you are coming from.
Thank you, esteemed panelists. I am Sharon. I'm currently 1 year from practicing medicine. And I'm interested in about private equities, about sending technologies into the world. So I would also like to ask Dr. Yuko from her previous remarks about the regulations and private sectors. So what are like the most difficult things to have a good product and put it out in the market? Is it the development cost? Is it the regulation that your products have to be on par? Or is it any other things that comes to your mind that is like the most difficult things to make a good product go into the market? Thank you.
Thanks so much. Let's take the second question and I'll try to make sure we address both that. It was an excellent question. Thank you.
Thank you. I'm Taketo Tanaka, technical advisor for the JICA's telehealth project in Vietnam. So my question is slightly related to the scaling, but also related to regarding the financial sustainability of such digital health initiatives. Yeah, because I see many digital health initiatives. Initially, which capital investment is funded by the development partners, for example. However, I often see that it's not sustainable because the government, the recipient government, do not budget for the maintenance costs, so that the invested equipment such as the data center or any equipment that will no longer be used, and it is the unfortunate and the waste of the development aid note. So my question is that if any of the panel members know any good examples to overcome such kind of challenges, how to ensure the sustainability of the digital health initiative by ensuring that the recipient government are committed to budget to for this digital services after the end of the development aid. Thank you.
Thanks for sharing that. We have one more in the queue. Please go ahead.
Yeah. Thank you for the lovely talk and the amazing case studies. And my question is regarding when we're talking about scalability, when we're talking about a lot of personal information about the patients being shared and the kind of geolocation tagging that we are going to use, how do we ensure certain safety standards and safeguards for this information? Because yes, we'll be requiring it to make the systems interoperable, integrating them, scaling them. So how do we address those? Because the kind of information we are collecting is very important, and systems not with can become predatory at any point, and then threats of surveillance. And so how do we avoid those things right when we are starting to imagine building different systems and making them grow better? Yeah.
Thank you. excellent question, particularly on we'll try to address all of them. Yuko, if I may first go to you. You had the question about the most difficult thing to take a product to market. And I might ask for all our other panelists, whether it's a product or a proven intervention, what's the most difficult thing after the evidence is there about taking it there? But if you wanted to talk about your own journey, that'd be great.
Yeah. I talk about can I speak about sustainability? Okay?
That too, sure.
Okay. いいですか？私たちも本当にサステナビリティが一番重要だと思っていて、そのためにはやっぱり現地の人々が払える医療費として払える金額に、していくということが続けられる、ポイントだと思います。またこれ私たちは機器を持っていきますが、これを、運用するのはやっぱり現地の人たちに、全部していただくようにしています。そうすることによって、一つは運用が現地のものに根付いていく。もう一つは、やっぱりこの機器を長く使っていただくということが非常に大切で、そのためには現地の人がメンテナンスできて保持もできるっていうようなことを、行っています。これに関しては、ちょうど私が今からこれが終わって日本に帰ったらブータンの方に、その保持の、研修を行うことになっています。
She's worrying about sustainability. And the most important thing about sustainability is, she mentioned several things. The first one is the cost, the price. Price should be the appropriately placed, decided, what the local people can buy and use. That is the first thing. So very low price. That is the first thing. The second one is the equipment is used by the local people. So the including maintenance, the system should be designed to be adapted to the local context. The third one is the equipment is designed to be utilized for long time. So the life cycle and the maintenance system to be developed in the country. So after coming back to Japan, she's going to have a training program to the vendors to strengthen the maintenance system.
Thanks for sharing that. Do you have a final comment on one of the most difficult aspects of taking a product to deliver? That was our first question from our first year.
それはですね、やはり医療機器っていうところの認証を取ることと、それからやっぱりこれが安全性を保っているというところにちょっと注力している部分です。
She mentioned this is a medical equipment, so the government authorities' approval is really essential, but it is really a tough issue. And to get approval, the safety is really important. So her company is paying attention a lot about the safety.
Thanks for sharing that around proving the patient safety model is a key piece. Let me ask a few of our other panelists to come in on our last few questions. And I don't want to ignore the brilliant point that was brought up about standards. Also something that comes up in my own day-to-day work, the fragmentation of data, even just the data standards, beyond safety standards, the procurement standards are similar. I often say fragmentation is like the chronic disease of health information and data. So whether it's the safety standards for accountability, the standards necessary so that we have a foundation to build further on, I'd be curious maybe, Nanjira, for you to talk about this aspect of, it links to that policy conversation earlier, whether it's the standards piece or the sustainability or some of those barriers for solutions and if they're related. Some of your final thoughts on these matters.
Sure. One that strikes me is that as digital health started to take off as a sort of subsector, we did have this unfortunate situation where the techies were speaking in different spaces and not necessarily including the health practitioners. And bringing those communities closer together is going to be very important for solving these bottlenecks. And I think the humility that is needed, especially by those more on the tech side, to realize it's not them alone who have the solutions. The people who've been working in the healthcare sector are experts as well, even if it's not on the terminology that we use in the tech space. This is going to be very important so that going forward, when we have digital health conversations or forums or that kind of thing, we have both sectors really represented in the spaces that we're deliberating and on the tables that we're negotiating these issues. I think the sustainability question that really tied to the financing, at least on this part of the world. And a question I always wonder is when the development sector introduces interventions, whether as pilots or other mechanisms, really how they honestly engage with governments about whether they can afford this, as was rightfully pointed out. We have this challenge where, especially where Africa is concerned, it's always almost considered that there's a land of lack. But I always like to say that it's the mismanagement, including by good intentions that have been brought in by different actors. Because how is it not possible to have a government come together? So even if it's going past silos where Ministry of Health speaks to Ministry of Finance about what this is going to be, who will set the standards? The Ministry of ICT. So this whole, as in Kenya, they call it whole of government approach. It's not just a nice to have anymore, it's a must have. But also within the development sector, how we also intervene in these respective countries, we also have to show how collaboration looks like. How does health speak to finance? How does it speak to agriculture? The things that are all intersected in trying to deliver on a particular point of intervention. We need to start showing that we are also speaking to one another and not just coming in through silos to really help incentivize ways that these interventions last beyond the time scale or the funding that is available. Mechanisms, we need more spaces, I think, to discuss this and really sort of workshop what have we learned from what has not worked so far.
Thanks for sharing that. A very concrete, good call to action on what's needed in that space as well. Rahul, I'd like to offer you the opportunity to come in on these topics around the sustainability or the role that standards might play, and any final thoughts you wanted to share with the panel and group today.
Thanks. I want to address the gentleman who's going to become a doctor in a year's time. And you asked a question that what's the most important thing which is required for a product to be put out there? There are many things which are important. You need to have great design, you need to have good tech, you need to have support for that tech to Indira's point, is can the government afford it? The single most important thing is the design user-centric. Have you built that product keeping the user in mind? And in fact, you've co-developed it with the user who's ultimately going to use it. In a year's time, when you become a doctor, you'll be exposed to many tech systems. And if you find them cumbersome and difficult to use, rest assured that they've probably gotten developed without other people like you having been consulted around whether they are working for you or not. So to me, that's the single most important thing that will determine almost everything which is going to happen in future. It's going to determine whether that product is scaled. It's going to determine whether that product is sustained. It's going to determine everything around that digital technology. So user centricity is really, really important, and that approach of bottoms up and not just top down is really, really important. I also wanted to quickly respond to the person who asked the question around security and data privacy. Really, really important in today's world, especially around the advent of cyber threats. 2-3 things really important: a very strong cybersecurity data privacy policy environment in the country where these systems are deployed. Tech which is used uses state-of-the-art tools, encryption technologies to develop that, so that those become hack-proof or cannot have information leaked out. And finally, the users who use them, and wherever the data gets shared, you need to have very strong policies around data use agreements and data privacy. So these would be the 3 things on the security side to answer that person's question. Overall, I thank you very much, Matt, for having us here. The one point which I may not have elaborated as much on is the key to using tech is to really keep it simple. You have to be absolutely ruthless about the number of data points you want to capture or the number of indicators you want to capture. Absolutely ruthless to the point that those are the most essential ones. When I worked in hypertension over the last 3 years or so, there are only 4 data points which can actually tell you the health of your hypertension program. And everything else is just additional information which can aid or cannot aid. If you know the amount of people who you have covered under the hypertension program, that's really important, because on an average, 15 to 20% of a population has hypertension, and less than 10% of them know that they have hypertension. So the first data point really is how many people you have covered. Number 2 is how many people have their hypertension under control, really your apex indicator. Out of all the people you have, how many of them have it under control? Third is how many of them don't have it under control? And fourth is how many of them are lost to follow up. They don't come back to care. These 4 data points in hypertension program give you the health of your program very, very easily. The others are important, but these 4 are good enough. So being really ruthless about the amount of information you need, because the more information you ask a frontline worker or a health facility worker to input it into a digital tool will just make their life harder. And God forbid that they have to do it on some paper form as well, because that's really the worst of both worlds. So really being ruthless about keeping it simple, keeping the indicators simple, and only taking information which is really required, regardless of whether using AI or any other technology or platform, is to me the absolute essence of scaling technology for service delivery.
Thanks, Rahul. Those are incredibly concrete and tangible points, which was a good call to action this morning. In our final minute, I just wanted to offer our opening speakers any very brief reflections on what was discussed today, or your own chance to come in. Miguel?
Thank you again for having this opportunity to attend this session. And we learn a lot of the cases from India, Japan, Canada, and we also talk about many non-technical and issues in the development of AI and other new technologies. And because I'm an economist, so I pay more attention to the non-technical issues. So, and maybe there are no definite answers for these questions right now, but maybe in the future and more evidence come up, and maybe we can look into a better solution or a better model for using the technology to build a healthier world. Thank you.
Thank you for this opportunity. Quite often what innovators do is to design for an utopian state of affairs. Instead, look at what is the state of art, what is the current state, what can you use from that, how can your technology or innovation work in the current ecosystem. Then it will scale. The other question to ask is, if your technology is going to be closed down tomorrow, who's going to lose sleep over it? If it is a key stakeholder at the highest level in the government, or someone who is on the front lines, who is needing to deliver care, and if they are going to lose sleep over it, then your technology is really worth it.
Thanks for those great comments, and thanks for also sharing the case today. I wanted to thank all of our speakers, our panelists, virtual, especially a big hand to the technical staff that supported the execution of this event. PMAC organizing committee for inviting everybody here. I invite everybody to stand if you're able to say thank you. And thanks also for the great questions from the panel. We're so excited to host you today. I appreciate you all coming. There's so much more that the conference has to offer. Over and out.